So CHF is a syndrome that occurs when the heart no longer has the ability to pump blood efficiently through the body. This inefficiency can result from several factors. The first is a decrease in preload, which is the ability of the ventricle to fill with blood. The second is a decrease of contractility. This is the ability of the ventricle to pump blood out of the heart. The third is an increase of afterload, or the arterial pressure or restriction that the heart must pump against. Right-sided heart failure refers to the decreased ability of the right ventricle to pump deoxygenated blood from the body to the lungs. Right-sided CHF can result in fluid buildup in the feet, ankles, and veins, which result in swelling, also known as edema. Left-sided CHF refers to the decreased ability of the left ventricle to pump oxygenated blood from the lungs to the rest of the body. Left-sided heart failure can result in the buildup of the blood in the lungs, which can result in decreased lung capacity, shortness of breath, and fatigue. In an effort to compensate for the decreased stroke volume, heart rate will begin to increase. Over time, this can result in cardiac remodeling in the form of enlarged myocardium with decreased cardiac output. Individuals who have coronary heart disease, high blood pressure, and diabetes can be predisposed to get heart failure. A medical diagnosis of CHF is based on medical history, family history, physical exam, and test results. If signs and symptoms do present themselves, the healthcare professional can listen for abnormal heart sounds, listen for fluid in the lungs, and look for edema in the body during the physical exam. Diagnostic tests that the healthcare professional used to determine if congestive heart disease is evident are a 12-lead EKG, which tests for normal or irregular rhythms, a chest X-ray to check for fluid in the lungs, and a BNP test to check for an increase in the BNP. And this can determine if the heart failure is present or severity of the condition, or a cardiac MRI to produce still and moving pictures of the heart and major vessels. Mr. Al is an 86-year-old Hispanic male who resides in a senior boarding care facility for the purpose of receiving assistance with completing his ADLs and for help with the management of his CHF, type 2 diabetes, prostate cancer, and mild dementia. However, the patient's signs and symptoms of CHF have progressively worsened upon arrival to the facility 1 year ago. The patient reports excessive fatigue and difficulty breathing while performing his ADLs. He makes frequent trips to the bathroom during the night with accompanying complaints of disruption in his sleep schedule. Additionally, the patient's normal weight, which normally ranges from 175 pounds or 180 pounds, has recently shot up to 187 pounds over the past week. His temperature is 98.6 degrees, his pulse is 118 beats per minute with a 1+ bounding and irregular rhythm. His blood pressure is 168/92, respirations are 24, and his O2 is 93%. Jugular vein distension is apparent at 9 centimeters. Heart sounds S1, S2, and S3 are present, and rales and bronchi are heard bilaterally at the bases of his lungs. Additionally, he has a Braden scale of 12. His extremities are at 4+ pitting edema over the bilateral tibia, ankles, and feet. Peripheral pulses are palpable at 1+, and mild clubbing is observed.
Nursing interventions. Diagnosis 1. Decreased cardiac output related to failure of regulatory mechanisms secondary to heart failure, as evidenced by a tachycardia rate of 100s to 110s and general weakness. Short-term goal. Patient will have an increase of cardiac output, as evidenced by heart rate and blood pressure within normal limits, weakness and shortness of breath decreased. Intervention number 1. Monitor blood pressure every 2 hours. Number 2, administer ACE inhibitors as indicated. 3, note heart sounds. And lastly, encourage periods of rest and assist with all activities. Long-term goal, patient's peripheral edema will decrease from a 4+ to a 1+ on the pitting edema scale by patient discharge. Intervention 1, obtain weight every morning before breakfast. 2, maintain fluid and sodium restrictions and educate the patient on healthy choices regarding food specific to Hispanic culture, such as substituting flour tortillas for corn tortillas and carnitas for grilled chicken breasts. 3, assess for distended neck and peripheral vessels, inspect dependent body areas for edema with and without pitting, and note for presence of generalized body edema. Lastly, maintain chair rest or bed rest in semi-fuller position. Short-term goal of obtaining increased cardiac output with heart rate and blood pressure within normal limits and decrease of general weakness was met, as evidenced by heart rate of 86 beats per minute, blood pressure of 122/82, and the patient stating, "I feel better when performing my activities of daily living." Long-term goal. Patient partially met long-term goal of improving their peripheral edema from a 4+ to a 1+ on the pitting edema scale, as evidenced by their peripheral pitting edema improving to a 2+. Diagnosis 2. Impaired gas exchange related to short and shallow respirations, as evidenced by respirations of 24 breaths per minute and oxygen saturation of 93%. Short-term goal, patient will have a blood oxygen saturation improvement from 93% to 95% or better, and breaths to be within normal limit of 12 to 20 breaths per minute. Intervention number 1, place patient's head of bed in 30 to 45 degrees position to best facilitate chest expansion. 2, administer and monitor oxygen therapy as ordered by the physician. 3, observe for cyanosis of the skin, tongue, and oral mucosa. And lastly, auscultate breath sounds, noting for crackles or wheezes. Long-term goal, the patient will transition from a non-rebreather mask at 15 liters per minute, supplemental oxygen, to a nasal cannula at 6 liters per minute as supplemental oxygen or lower. Intervention 1, monitor ABG values and pulse oximetry. 2, administer medications as indicated, such as the following: diuretics, like Lasix, bronchodilators, like aminophylline. 3, auscultate breath sounds, noting for crackles or wheezes. Lastly, provide assistance with ADLs, intersperse activity with rest periods. Short-term goal was met as evidenced by blood oxygen saturation improvement from 93% to 96% upon assessment with a pulse oximeter, and breaths being within normal limit of 17 breaths per minute. Long-term goal was partially met as evidenced by patient's need for a non-rebreather mask at 10 liters per minute, which upon physical exertion which exceeds 10 minutes. Diagnosis number 3. Risk for impaired skin integrity related to prolonged bed rest, as evidenced by Braden's score of 12. Short-term goal, the patient will not develop pressure sores while on prolonged bed or chair rest by the end of shift. Intervention number 1, inspect skin, noting for skeletal prominences and presence of edema. 2, provide alternating pressure or egg crate mattress and sheepskin elbow and heel protectors. 3, provide frequent skincare, minimize contact with moisture. Lastly, provide gentle massage to at-risk areas. Long-term goal, patient will not develop redness over bony prominences while on bed rest. Intervention number 1, reposition the patient every 2 hours as needed while on bed rest. 2, monitor skin condition at least once a day for color or texture changes or lesions. 3, elevate the bed of no more than 30 degrees. 4, remind patient not to slide over the sheets when transferring from one place to another. Short-term goal and long-term goal were met, as evidenced by the absence of pressure-related sores.
Managing CHF involves positive lifestyle changes such as healthy eating habits, self-monitoring, and routine medication administration. It is important to ensure that the patient has a firm understanding of CHF, how the disease is affected by external factors, and the precautions of not making the appropriate dietary and lifestyle adjustments suggested by the healthcare provider. Without the obedience of the patient in regards to the new diet restrictions, medication regimen, and lifestyle changes, their quality of life will continue to decrease as health complications will persist. Minimizing the amount of salt in the diet will help decrease thirst, resulting in less water retention. This is an easy alteration the nurse can suggest to the patient. Having the patient assess for swelling in the lower extremities on a daily basis is another way to keep the patient active in their recovery. A diuretic is also a common type of medication used in patients with CHF to help minimize fluid buildup. Therefore, it is important for the patient to be strict with their medication regimen. An active lifestyle will complement the newly adapted healthy eating and medication routine. Although there is not a cure for CHF, by setting a roadmap of care for the patient, nurses provide the tools and knowledge the patient needs to address their concerns, anticipate the future, and manage the present.